Yeah, so the study fundamentally is trying to understand different ways of influenza pathogenesis. So a lot of work in the past, rightly, has focused on the effects that influenza has in the lung, and of course, it's a substantial pulmonary pathogen that is a source of a billion infections and many many deaths, hundreds of thousands of deaths worldwide every year, and it's there every year. And so if there's massively appreciable amounts of literature on the effects of influenza in the lung, but there is also clinical observations or clinical anecdotes suggesting that although there are many deaths, et cetera, coming from influenza, that those that survive may have lingering effects and aggravation of cardiovascular disease and cardiovascular issues. And so we primarily used the mouse model to sort of explore the effects of influenza on on the heart. We then sort of extended these observations to seeing that the pathways are at least conserved in humans and patients and potentially in those that succumb to influenza. But what we found is that there's this relatively newly described, somewhat atypical leukocyte that is responsible for trafficking influenza from the lung to the heart, and it sort of allows the virus to seed the heart and damage the heart functionally and also sort of histologically. And ultimately, the cytokine responsible for this damage was type 1 interferon, which is a very interesting, somewhat pleiotropic cytokine that is very important in the lung and antiviral immunity, but it has a lot of off-target effects. And so it really needs to be sequestered in other areas outside of the lung during active infection. And so what we found is that we get this sort of upregulation of the signal in the heart, and this ultimately was responsible for the cardiomyocyte death and decline in cardiac function. And so then finally, fortunately, we have some clues of how we can target this pathway, this type 1 interferon pathway. We did a few different methods. Sort of the most eloquent, potentially most clinically relevant is the usage of modified mRNA to downregulate the signaling specifically in cardiomyocytes and to protect them while conserving the beneficial roles of type 1 interferon in the lung. Yes, so that's yeah, hugely important. So I think the question, as I sort of mentioned, I think clinically there's always been an appreciation that influenza is bad for the heart, or if you have a large amount of cardiovascular comorbidities, influenza is going to be worse for those comorbidities. But what we sort of provide is that there is um, that this is valid. We've provided mechanistic insight sort of experimentally as to why this may be. But I think the mindset is that we should be thinking about this in that influenza has the capacity to sort of leave these lasting scars. And so it's something to always be paying attention to is that, perhaps just getting through influenza is not, the only goal. The main thing we should be focusing still on prevention of infection, mitigation of infection, and ultimately in those with high risk, as you said, potentially looking at some of these immunotherapies that can dampen sort of immunological pathways activated specifically in the heart. That would be sort of if stratify people based on their risk and then sort of mitigation of the risk from there. That's a very good point. So I would say that the point of intervention would likely be the type 1 interferon pathway. The cell type, I would say, although there's potential there, it's would be more difficult, at least with what we know now, to target specifically. So one of the findings there that we have that is sort of from a very much immunological fundamental understanding is that it overlaps a lot with other sort of cell types. And so specific targeting, although it's highly important, specific targeting is, as of now, is very difficult. So the markers are a little bit ambiguous. Its lifespan is a little bit unclear. How we would go about targeting it in the blood or preventing it from moving from the lung to the heart. Also, one of the major shortcomings or one of the future directions is understanding does this role, does this cell have a beneficial role from there? Are we missing something? So we point out detrimental things in the heart, but presumably evolutionarily we have this cell for some reason. So if we just blanketly remove this cell type, we may have some undesirable consequences that we haven't considered yet. But ultimately, what we were able to show is that the fundamental source of the damage in the heart is type 1 interferon binding the cardiomyocyte. And so no matter how we prevented that, so we did do some inhibitory studies in mice involving certain cell types as proof of concept, we could do that. But ultimately what mattered was preventing the cardiomyocyte from seeing type 1 interferon. And so that's probably the most tangible. And in fact, we have sort of submitted a patent in this regard to kind of pursue this in the future. And then finally, to conclude, one thing that's particularly appealing about type 1 interferon is, as I mentioned, it's ubiquitously important, mostly for viral infection. And so in theory, it could be that while influenza may sabotage a specific cell type or the kinetics may be different, other viruses like SARS-CoV-2 or chronic illnesses as well may have this same effect of type 1 interferon cardiomyocytes, which in theory would all be prevented by blocking type 1 interferon. Yeah, so it challenges it, but it also complements it in some ways. So the major observation there, sort of from viral pathogenesis, is that in the lung you have this overwhelmingly large viral load, and so at least in the mouse model, which is also true in humans, you have that is the primary site of replication. And so in the mouse model, at least with these sort of doses, you're seeing millions of viral particles that are primarily replicating in epithelial cells of the lung. And so that process is, in some ways, it's overwhelming for conventional modulation of the immune system outside of vaccination. Blocking that, blocking, lowering initial viral titers through vaccination, et cetera, is the way. But once we have sort of this viral foothold, it's extremely difficult to prevent it from damaging the lung. So what we see is that this type 1 interferon process there is necessary. It's sort of that if it didn't exist at that point, you're going to succumb due to respiratory insufficiency. And so it's sort of like, oh man, we're in trouble. Let's kick in the type 1 interferon program. But from that point where we have sort of these secondary tissues that are becoming affected, it gets activated somewhat prematurely. And so although we see low levels of replication in the heart, we would argue that you don't need this full-blown antiviral response. And so sort of show, and it begs to reason that we can prevent that, allow things to occur in the lung, allow the type 1 interferon response, but just minimize it in sort of other tissue sites. Yeah, yeah. So that's yeah, right, exactly. So that's a little bit what I was sort of trying to get to earlier, is that it is somewhat contradictory, but it is also complementary in terms of the tools that we're starting to employ. And so, as I mentioned, I would say that bar none, a functional type 1 interferon program in the lung is essential. And so we've seen this with SNPs in humans, SARS-CoV-2, influenza pandemics. Those that have um, uh, issues with the type 1 interferon pathway, either genetically or through immunosuppressive drugs or other diseases, will have a tough time. The severity is almost certainly to increase. In the heart specifically, what we're at least able to do using some of these new technologies is we can have the expression limited to the cardiomyocyte. So this is not the primary site of infection. This is not the primary site of damage, even to a large degree. So what at least the therapies we're proposing will allow the lung to behave completely the same. And we have shown this, that the antiviral capacity in the lung is completely intact. And when we deliver this modified mRNA directly into the heart, this is how far we've gone now, that will then lead to a sequestering of the type 1 interferon signature by having a dominant negative receptor. We prevent the cardiomyocyte death. Where we're hoping to take that is that we don't. So this obviously in a mouse involved. This is purely experimental in preclinical models. We open up the chest, we deliver the mRNA, modified mRNA, specifically into the ventricles, and that protects the heart. Obviously, this falls short of clinical expectations, and so how we're trying to modify this is using this new mRNA this new mRNA system that's partly been used for the newest COVID-19 vaccines, but also being improved for specificity with certain individuals in the CVRI, primarily Lior Zangi, is that we can deliver it systemically. And in theory, this is all true. We haven't tested it specifically in the influenza model, but we can deliver things systemically, and then it will, it travels systemically, but it only gets expressed specifically when it sees another RNA within a cell type of interest. And so if the cell type doesn't express cardiac specific mRNA, such as troponin or alpha myosin heavy chain, various cardiomyocyte proteins, you don't get any expression. And so as a result, you can just deliver this intravenously or systemically, and you can even infuse it over longer periods. It's quite tolerable. And what we would hope is that when we think about this in the viral infection, again, we leave the type 1 interferon pathway intact in the lung, but we specifically prevent the collateral damage in the heart.